Very good evening and welcome to all of my beloved colleagues today. Hopefully, you can hear my voice and seeing the screen well. Can anyone respond, please? Doctor, can you?
Yes, sir. Voice is clear, sir.
Okay. And the screen okay, doctor? Is screen okay?
Yes, sir.
Thank you very much. Thank you very much. So, we are in time, all of you, and very mm, gratefulness to all of you to be in time. And we started, usually, we try our best to start in time. So, with my humble introduction today and from the Institute and with the moral alert as well, these are restricted material. And today's topic assigned, all of you know in the meantime, but we like to start in a different way to you. Uh, our learning process in all of our sessions, you observe that we try to deal a patient. Book knowledge is knowledge, just as reference. So we usually try to start with a patient, how we read a patient. This is our challenge. So let's see a patient, and for all of you, I'm actually going through my patient. You just listen to me carefully, and will give your opinion. A 42-year-old woman with symptoms of anxiety comes to the surgery complaining of intermittent pleuritic chest pain, particularly when she is under stress at work or undertaking unexpected exercise. She has passed out on one occasion and says that sometimes she notices pins and needles around her mouth and in both hands. This is the scenario. So, which of the following is the most appropriate plan for her? Before giving the decision, you need to have an idea of diagnosis in your mind. I think the scenario is clear to you, but I'm requesting all of you to share in the discussion what you are thinking. What will you do? Please, anyone to give the answer? Then we can proceed further. It is very interesting topics today, and all of you know in the meantime what is the topics today. What is your diagnosis? First, Dr. Arvind, please. What is the diagnosis?
She's having panic attacks.
Panic attack. Attack is one word. If it is persistent, recurrent, it would be said as panic disorder. So you are thinking panic attack, and then what will be your management plan?
CBT and SSRI would start.
Anyway you will think it could patient should have psychological treatment. Okay, this is one of the aspect of the patient. We say always patient that in especially in the family medicine, biologic, psychologic, social issue. So you identified and diagnosed the case in the psychologic point of view. So if it is the diagnosis, your treatment could be right. But other colleague, what you are thinking? Are you thinking this is asthma, bronchial asthma?
I think more of COPD. Assalamu alaikum, Dr.
Oh, Assalam. COPD, why you are thinking? 42-year-old woman.
And written that she is feeling pins and needles. So if
Uh,
more
uh, Hyperventilation. She's having
hyperventilation,
hyperventilation.
it's because of
Yes.
hyperventilation
So hyperventilation you are thinking, but it is a feature of
or bronchial
COPD.
asthma, COPD, bronchial asthma.
Not
So,
COPD.
so tell best of 5 answer or best of 6 answer, Dr. Javed. Dr. Arvind said that it is the panic attack. That means a psychiatric diagnosis. What is your diagnosis? Will you say
COPD, COPD,
COPD?
acute exacerbation of COPD.
Exacerbation of COPD. Okay. Any other colleague to interact or discuss the diagnosis, or any having second opinion, third opinion? Dr. Arvind, why not?
So,
Sorry, yes, Dr. Hoor, please.
sir, what about exercise-induced asthma?
Undertaking unexpected exercise. The word is diplomatic, not usual exercise. The exercise induced asthma would happen in as usual exercise. So it is exercise induced asthma. But if you want to say the asthma, what other feature should be there? Is there any features of atopic? itching, sneezing, running, exposure, trigger factor, or even little family history. Okay. And why, how you, Dr. Hoor, please, why you disconnected? Pins and needles are there. How you can say that this is asthma? Can happen in asthma, pins and needles?
No, I'm not actually sure, but the stress and the exercise, that's why I'm thinking.
Okay. Actually, our topic today, not to discuss all of the diagnosis of breathlessness or something. Actually, patient having the background of anxiety, right? Sorry, features of anxiety means patient was having anxiety and complaining pleuritic chest pain, intermittent pleuritic chest pain. She is under stress. You see, a stressful situation, and especially you see the particularly under stress and undertaking unexpected exercise. At that time, patient have pleuritic chest pain. You understand meaning of pleuritic chest pain? Do you think that in asthma, pleuritic chest pain expected? Dr. Javed,
No.
can you be with me also? Another colleague open the mic to say something.
Oh, I think not expected in this.
Not expected. Pleuritic chest pain is a feature of pneumonia if it involves the pleura. Again, pleuritic chest pain could be features of pneumothorax as well. Even the pulmonary infarction, that is after embolism, could be. So in the asthma, there unexpectedly there will be pleuritic chest pain. But apparently, we are thinking that patient might have ventilation issues, right? Pins and needles is the features of the ventilations. Okay. So if you think that it is asthma, you will be in mistake. And if you don't understand the what is the diagnosis, your answer will be wrong. So if I give these keywords for you, is a female patient, pins and needles, could be more likely hyperventilation syndrome. And if it is hyperventilation syndrome, what will be the best treatment?
Uh, that would be, sir.
Which one?
That would be like
Breathing and then
breathing
Referral for
close.
cognitive behavior therapy. Cognitive behavior therapy. Okay. So their similar answer may be trial of SSRI also. But the best answer, if you think cognitive behavior therapy, the cognitive behavior therapy. That's right. Fantastic. So these are other thing. What Dr. Arvind said that yes, it could be part of the panic attack. Panic attack means if persistently happening, panic disorder. One of the presentation of the panic disorder is the breathlessness, chest pain, tightness, and other things in the background of anxiety. But why I raise the issue? Today, you know that our topic will be what? Who can say what is our today topic? Our today topic. This is another issue, the management part and others. I am not highlighting here. Our topic is actually this one, bronchial asthma management updates. This is the topic. And but in our practice, in the general practice and emergency room, this hyperventilation syndrome we treat most often as severe attack of asthma. Who can deny my opinion, please, that it is not? It is my observation, humbly saying. We are giving bronchodilators, we are giving steroid, we are giving oxygen in such patients. So all severe breathlessness is not bronchial asthma exacerbation or acute attack of bronchial asthma. For this reason, we have to be very alert to diagnose bronchial asthma, otherwise treatment will be wrong. So as we are talking today with these, and we told you that the recent updates we should have in our front today, and we will be talking on the management of the bronchial asthma. This is our references, even the AKT exam or in the OSCE exam also, you have to give some evidence-based informations, not what you are practicing. So you have seen already one before, this was the GINA, and this one a combined opinion given in the last 2024 by the NICE guideline, British Thoracic Society, Healthcare Improvement, Scotland, that is the sign. And if you go through until 24, last 24, to 2024, there are variations in the opinion, and our colleagues are confused. What will be the best answer? Who did not fall into this problem? I think every of you, right? Dr. Javed, what do you think? The decision making of the asthma management we sometimes confuse, because in our textbook is telling something. Okay, textbook in the general practitioner is telling one thing, medicine book another thing, mentor is telling one thing, sign guideline telling another thing, nice guideline another thing, British Thoracic Society another thing. Am I right, Dr. Javed?
So I think it's different opinions. Yes, you are right.
Yes, yes. And it is written in the book also. Your GP book, you can see there. So very interestingly, I think it is we are in the comfortable zone. For example, NICE guideline and sign guideline, especially NICE and British, you know, there is all, both are British. Even then, they have difference in opinion. Still, what you have in your learning modules, I am humbly and feeling sorry also to say you, the learning material given to you, those who are using the module, the decision making is not perfect now for coming exam. For this reason, I am very actually, what I said, desperate to organize this topic today. It is very important for AKT and OSCE in future time, when especially there will be discussion of the management regarding the investigation as well as the management of the disease. So uh, today, I hope session will not be too much long, but very important and interesting. Just be with us, and you will have an outline that what will happen in future, and you will ignore your actually learning material also somewhere. I will let you know in the later part. So this is the bronchial asthma today, our main topic. And before managing, especially before managing, what is in your mind in the asthma? First of all, already you understood the diagnosis, right? Okay. So what other thing, Dr. Javed can start with us. What other thing in our mind at the time of treatment? First of all, am I right to diagnose or not? Right? This is okay. Then next, you are
Correct, correct.
confident for the diagnosis. Then what is in your mind?
I mean, obviously, first the diagnosis and then the severity.
Severity, right? Is there any severe asthma or not? Features of severe asthma. Very
Stepwise
right.
treatment. And,
Then
then you have to start with the stepwise treatment. Initially, obviously, we are starting with the bronchodilators, short
that
acting.
is okay. This is management. I'm thinking that what should have in our mind that first of all, is there any feature of severity or not? Then another question.
And atopy, association with
Is there a
atopy.
background of atopy? Atopy actually help in the diagnosis. Okay. Then
Presence of pets, I mean, allergy with anything.
allergic. That means the trigger, rather to say triggers.
Yes.
Any feature, any background history of the triggers, because trigger exacerbate the asthma feature. Okay. And then any
Then
complication of the asthma?
yes, then
Any complication of
peak,
the asthma?
yes, complication of asthma. And then I think with peak expiratory PEFR.
What is the
Uh,
value of the PEFR? So I
then
will do after having in my mind, I will take the action to measure the PEFR if it is a follow-up patient, right?
yes, we can do in the clinic or at home also.
All right. In the asthma, is there any features of severity? This is first question. So you must know it about, and many other questions will be there. If you are confused, it is asthma or not. First of all, if you are confused, it is asthma or not, what other differential should be considered? Very allied.
COPD.
Exacerbation of COPD, one another.
Then occupational asthma.
No, this is asthma. I'm telling it is not asthma, other than asthma.
Okay.
What Dr. Gufran, please? Dr. Tuba Gufran.
Pneumonia.
Pneumonia, you are thinking like asthma. Less likely, Dr. Pneumonia would have fever, productive cough. So it is not very closer to asthma. Other?
Or heart failure.
Yes, yes. You can say heart failure, right? Then acute heart failure. Then
Bronchitis.
bronchitis is a part of the COPD already. Then could be pulmonary embolism. Pulmonary embolism. Okay.
Yes.
Another one, Dr. Javed, better to think. Another one in a different angle is a metabolic problem. Is there patient having breathlessness? Isn't it? Could be no, without obstruction. It could be uremic breathing also there. Isn't it? Haven't you see before?
Yes,
uremia with the breathlessness
uh,
could be there.
chronic.
At that time, scenario may be beyond your grip. Okay, so again, I cannot control this to be discussed, but I am not going there how to diagnose, but I'm thinking that during the time of diagnosis, many things should be in our mind. Okay, anyway, we diagnose the asthma. Now, in the part of management, what clinical data, other things should be in our hand? I was thinking this thing for the management of, we must have SpO2. We have to measure the respiratory rate, pulse rate, 110. Okay, pulse rate. So what is this actually? 110, pulse rate 25 minutes. It is the features of severity. Cyanosis is the features of severity. Peak expiratory flow rate, what Dr. Javed said, including the age. Why should we know the age? Dr. Arvind, why should we know the age?
Because it affects the treatment.
Treatment
Yes,
and
yes.
management.
Management, because the guidelines and other treatments set according to the age, right? But not the gender. Why gender is important? Gender is important, especially if the patient female and pregnant or not. For this reason, gender is important. That am I treating a female or not? If it is female, then she is pregnant or not. For this reason, selection of the drugs will be different. And the background of the exacerbation previously, the triggers already we discussed. Inhaler technique is very important. Inhaler technique, you are following a patient came to us, that patient telling that my asthma shoot up, my breathlessness is not under control. This is one. Oral candidiasis, why important?
Because of steroid inhaler, I think.
Yes, usually we advise steroid, and steroid can cause very commonly oral candidiasis. We have to look after these. Okay, and there might be some other thing also. Anybody can add more than that, what I have shown here, Dr. Arvind?
Sir, oral candidiasis maybe is immunocompromised. Patient is immunocompromised.
This is another background, but we are dealing a suspected case of asthma. And how patient will be immunocompromised, Dr. Arvind better, because, and we congratulate you, Dr. Arvind. Maybe your session is very interesting for you, but we arrange AKT for an OSCE more than, but you are gaining and for all of you today, it is our pleasure to congratulate Dr. Arvind, just passed OSCE in the last time. I think Dr. Arvind is happy to be with us in regular session.
Yes,
Right.
sir.
And thanking you, Dr. Arvind. Other thing, how you explain the candidiasis in the asthma patient other than steroid inhaler? A little different question for you. If patient is abusing oral steroid, right? Then we can say patient might be developing underlying immunocompromisation. But by the what I say, inhaler steroid doesn't produce so. Okay, Dr. Arvind?
Yes, sir.
And this is the other broader spectrum understanding. Patient might be using oral steroid because it gives very early relief, very good relief. Patient might be fond of it. Another way. So keeping in the mind, let's see what other thing we should know in the management of asthma and the investigation now. That these are not investigation, doctor. Remember, these are your clinical weapon. Already I told you, peak expiratory flow meter should be in your hand. It will be part of point of care test. I think all of you in the meantime have heard it. Point of care. The device is in your hand. Especially you see what is this? Oximeter also. It is not investigation. Investigation means what you are getting by sending the sample to the lab. So is there all are important? What do you think? Again, without understanding these, you will not be able to manage your asthma perfectly. For this reason, I am showing this initially. I will show you the other core messages. Is the CBC important to manage asthma? And how? Dr. Javed, please.
Yes.
Dr. Tuba. Dr.
Because,
Tuba.
because
Allergic to-
immunophysical
Sorry. Dr. Tuba, please.
Feels.
Dr. Tuba.
Sure, eosinophil count.
Eosinophil count can
eosinophilia,
help. Okay, it can help in diagnosis, but without eosinophil also, will you change your mind about the diagnosis of asthma? Eosinophil will not be very good
yes.
marker for diagnosis, but it can help. For right. Any other clue in the CBC? Any other clue?
If WBC is high, then you can think of infection
Yeah,
as well.
Infection inside. Can WBC high can give some other background message other than the infection? Again, question to Dr. Arvind. If any other colleague who have passed already OSCE, question to you.
Even
High
COPD
WBC.
in high WBC or
High WBC, leukocyte count. In the CBC, you are dealing a patient of asthma. Let me give the answer. Again, if patient of a steroid abuser and taking high doses of steroid can be cause of high WBC. Okay.
yes.
So very critical thing may be there. Anyway, don't like to go beyond this. Remain as GP here. Discuss with very simpler way. So CBC simply can give an infection. Okay. Then in a hypoxic patient, for example, if patient is anemic somehow, patient will suffer more, is not it? If hemoglobin is low, is not it, Dr. Javed? So
Yes.
CBC can give us in many ways. And
That
now serum IgE is important to measure. I have put this word intentionally because I saw randomly most of colleagues are advising serum immunoglobulin E. Is it needed for all patients? Sometime not, sometime not. If I am confused whether this is atopic breathlessness or breathlessness due to other disease, at that time, if serum IgE is positive or raised, then we can think that it might be due to asthma. In this way, it is important. Sometimes too much IgE can give us different message. It is not the topic of today again. Spirometry with bronchodilator reversibility, post bronchodilator reversibility. Do you think it is important to know?
Yes, important.
Yes, important. And the pheno?
This is also important.
It is also practiced. And
Yes,
even
important for the
pheno. What is the meaning of pheno, Dr. Tuba? Dr. Thalia was interested. I found Dr. Thalia. Maybe you are interested to talk. Please, can you open it? Dr. Thalia, maybe I saw here. Pheno. What is the meaning of pheno?
Fractional excretion of nitric
Not
oxide.
excretion. Exhaled, possibly. Fractional exhaled nitric oxide. Okay. Exhale nitric oxide. That is then detected and say this is asthma or not. Chest X-ray important for asthma patient? Chest X-ray?
Yes, I think.
Yes, but already we said that there could be pneumothorax also. Okay, very severe asthma can complicated with the pneumothorax. Okay, an X-ray can give again if I think that there is an associated infection, even the pneumonia also can be visible. So up to this enough as a GP, but patient may need to be done for HRCT or other for many other purposes. But these are very simple. Keeping in this mind, again, our next patient, Dr. Javed, please can help me.
You are evaluating a 35-year-old patient with known asthma. He comes to your office complaining of increased shortness of breath despite compliance with his usual asthma regime. He reports cough but denies fever or sputum production. His pulmonary examination reveals bronchi bilaterally without crackles. Which of the following is most useful action plan in this setting?
Yes, what will be the action plan? Now everybody can share.
we can give bronchodilators.
Most useful action. You will give bronchodilator. So if you say about your OSCE exam, you have to say the best of 5 answer or single best answer. You are thinking you will give bronchodilator. Patient is already on this treatment, no doubt, right? Because 35-year-old patient known asthma. So today you are following the patient, monitoring the patient. Patient having symptoms now, is it? Dr. Jabed, patient having the
Yes.
symptom, complaining of increased shortness of breath. So you are giving the medication. Fine. Dr. Jabed, what is your plan? Any colleague, please share. Dr. Arbin, if you are free to talk on it.
Sir, we
Best.
can give bronchodilators.
Okay, finish. You have chosen the best is bronchodilator then. So silent. If you are silent, how can
Starting
you manage? How will you manage?
Steroid inhaler also you can add.
Let's
Already
see
she
now. No, my question is, will you give directly now the medication? Will you have further evaluation, state of the oxygen saturation or peak expiratory
you
flow
will do the
rate
examination. Yes.
or
Yes.
spirometry again?
Yes, spirometry, FE, yeah, peak
There are
expiratory.
many options will be there, but for AKT exam, you have to choose the best one. If you say all are possible, but all are
Peak
will not be
expiratory
good
flow
for you.
rate.
Which
Peak
one, doctor?
expiratory flow rate.
Peak expiratory flow rate. It is your
Peak
decision.
expiratory flow
Peak
rate.
ex- okay.
Yes.
Keep the answer with your mind, and we will follow the question again in the next time, in the coming. Before going there, come to the diagnostic weapons with us. What we do. I will not describe details here. This is the bronchodilator reversibility test. Okay, whatever you need, you can make a snapshot or you can request in the group later. So this is that one. It is explaining bronchodilator reversibility test. And these are the parameters how to evaluate this test for the diagnosis of asthma. There are some features of reversibility, 20% diurnal variation and others. So we diagnose the asthma by the spirometry as well as peak expiratory flow rate. But main important thing, this spirometry with bronchodilator reversibility. It is the best one. But peak expiratory sometime we use. So the reversibility test, if salbutamol test inconclusive, and at that time we use the steroid. So this is the way, and this is a complete slide for you to know about the bronchodilator reversibility test. Okay, especially for the OSCE, these data are very important, very practical data. Okay, for that we invited OSCE and AKT together here. In your book, regarding the diagnosis of asthma, again based on the probability, clinical probability. I will not detail too much. If probability is high, even without the spirometry, you can start with the treatment. And some of the questions you could remember, those who passed AKT already, that there are some questions without doing these, you already started steroid and others. It happened. But if the probability is very low, then you should search for the alternative diagnosis. Asthma is unlikely. Even then, we need to exclude asthma by doing a spirometry. So this is the main area where a spirometry potentially mandatory to say no asthma if probability is low. That means asthma should have some clinical background, should have some clinical features with us. Okay, fine. And then, sorry, the message is that if spirometry is normal, all the time we cannot say this is no asthma. It is also true. It is the limitations of any investigation like spirometry and other, because asthma is a disease of up and down, with symptom, without symptom. So without symptom time, if you advise a spirometry may be normal. Take care of it. And this is that peak expiratory flow meter. Okay. And this is then AM, PM variations we can see from there. So these are the diagnostic tool, all of you. And this is another one, the graphical presentation of AM, PM. Okay. And usually used for the occupational asthma at the day of holiday, which holiday mentioned here, Dr. Javed, in this graph? Saturday,
Weekend,
Sunday, Monday,
on the weekend, when
weekend.
we are
Which
away
day?
from the
In the graph, which is weekend here?
Saturday, Sunday.
Saturday, Sunday. That means the Western, right? Even in some other country. But in our South Asian countries, especially those are the Muslim countries, their weekend is the Friday. Isn't it? Few Muslim countries having the Friday. So we need to consider this also. Which day is the holiday? Which day is the office day? In this day, the AM PM variations will be there like this. If it is like in the active hour, then it will be occupational asthma. So peak expiratory flow rate have some special quality, or what I say, the importance or significance to diagnose occupational asthma. Because in the holiday, if you advise for the spirometry, it may not give the result. Already we have shown that the spirometry in the asymptomatic time, it may be normal. In those situations, occupational asthma to be detected more by the peak expiratory flow rate. Okay. Peak expiratory flow rate is useful for diagnosis. Peak expiratory flow rate is useful for monitoring, which is more best answer.
For monitoring.
For monitoring, right. Agreed with you. Thank you. For monitoring, peak expiratory flow rate is more valuable than diagnosis. Okay. And these are the nice guideline or nice recommended tests pheno, obstructive spirometry that we discussed, bronchodilator reversibility also we discussed, right? Obstructive spirometry, that is that one, the ratio. So peak flow variability, this is another way, peak flow. So peak flow is number 4 here. And other bronchial challenge test with histamine or methacholine. Okay, that was actually we have collected these few years before from the previous guideline. Okay, but we need to know the update. And what is update here? You see, patient above the age of 16 years and how to proceed with. Now look at the picture, everybody. What will be the best method for diagnosing asthma?
Pheno.
Initially, pheno or blood eosinophilia, right? You see, blood eosinophilia. If their blood eosinophilia, it will be useful. But absence of blood eosinophilia does not exclude. It is also true. Next, if pheno is not possible to be done or eosinophilia is not there, then we could think of bronchodilator. This is actually popular and all the time we do it. Bronchodilator reversibility test with the spirometry. If it is not done or cannot be done, it is delayed, and actually it is not in our hand usually, right? All center is not equipped with this device. Then peak expiratory flow rate. Then bronchial challenge test. It could be risky also. So best utilized investigation is bronchodilator reversibility test. It is true. Okay. And interpret the result. Okay. Then you come to the decision. With suggestive history, then you diagnose the case. So without history, only by the test, you cannot say this is disease. Remember it. With history suggestive of asthma, you can see in the bottom box, then you confirm the diagnosis of asthma. But for the treatment, with the probability, we can start the treatment. We don't need to diagnose the asthma all the time. If there is no alternative diagnosis, then we can say this is asthma. Okay. Again, this is then age. Younger age children, age at 15 to 16. What is the difference here? Pheno. You see pheno. But eosinophil count is not mentioned here. If pheno available, again pheno took the lead for the diagnostic weapon. Then bronchodilator reversibility, then peak expiratory flow. And what is the difference here? Is it difference? Is the different here? In the last box, in the diagnostic. Previously, what you have seen? Adult patient. In this fourth
Yes,
box,
methylene challenge test.
Methacholine.
yes, challenge test. That means bronchostimulation test. But for the babies, these are not advocated, right? So it could be the area where a MCQ question could be given as single best answer for the children. Remember it, because you are family medicine candidate, not MRCP part 1. So you are dealing both babies and the father of the baby also, mother of the baby also. This is separate. Skin prick test, total IgE and blood eosinophil is the last one. So IgE have some role also, especially in the baby's diagnosis. Eosinophil also, but in the adult population, eosinophil could give better information early. So this is another difference. Now again, with history suggestive of asthma, you are starting the treatment. Now again, come to the case here, the same case. Dr. Javed, can I request to repeat the scenario as you have gone through before?
You are evaluating a 35-year-old patient with known asthma. He comes to your office complaining of increased shortness of breath despite compliance with his usual asthma regime. He reports cough but denies fever or sputum production. His pulmonary examination reveals rhonchi bilaterally without crackles. Which of the following is most useful action plan in this setting?
Yes, now decide. Now my question to you here, are we planning for the diagnosis asthma again, or are we following the patient?
Now we are following the patient
We're
already
following the
diagnosed.
patient.
We are following the patient.
We're following the
We are
patient.
following.
So if we, before giving further therapeutic decision, what do we have to do now?
We
Patient
will do
already
a
diagnosed.
peak expiratory flow rate
Peak expiratory flow rate.
parameter.
Usually it is customary to advise the patient to show his home peak expiratory flow rate, right? Home monitoring, isn't it?
Yes,
Yes.
What is the idea? It's a home monitoring, home plan we already given. Though we don't do it, Dr. Javed, we are sorry to say. But ideally, patient is to have a peak expiratory flow meter with him, like glucometer for the diabetes. They will show. Now, as a GP, I should have a peak expiratory flow meter also. In this way, we can say, okay, put peak expiratory. Now, these are the options. Do you agree with the same opinion or have different opinion? Please, other colleague, open your eyes. What you like to do in this background? Other colleagues are silent, telling nothing.
we go for peak flow rate testing.
Peak flow testing is the same, all different. I am willing. Dr.
Yes.
Gulzar.
The speed flow
Peak
testing.
flow, all are peak flow.
Flow
Okay.
testing.
Yes.
Okay.
Yes. Peak flow rate.
Don't be biased today. Okay, if biasness is in a good way, this
Question.
is good. So this is the peak flow testing. Already that is our target to let you know how to evaluate the patient in asthma. This is a part of the management, right? Before giving the treatment, we have to check the peak flow testing. So those who are appearing a KT exam, if you think that I will give some bronchodilator, I will increase the medication. Usually we used to do it. Doctor, some doctor said that I will give the bronchodilator. Can you open the mic, please? I will feel better to talk to you. And this is our real
Yes,
experience,
yes,
Dr. Tuba. We do it, right? We do it in
yes,
general practice. Without
yes,
evaluating the patient, without making the notes of the peak expiratory flow rate, we are giving, okay, take this. Steroid high, other high.
yes.
But it is not ideal. Ideal thing is in this background, peak expiratory test and record and be confident. So peak flows do not confirm diagnosis, but useful to monitor the status of the known lung disease, that is the asthma. This is the best answer. Okay. Now come to again asthma management issues to highlight more than 12 years of age. Stepwise, we will discuss. Already some of you attended maybe a few months before. So we are actually reorganize this thing. Before going to this algorithmic approach, we like to let you know, we will discuss this thing in between in the algorithm discussion regarding this low dose, moderate dose and high dose steroid. So you will make a note and have a snapshot here that what will be the in which drug should be graded as low dose and high dose. Yes, Dr. Saima, please. Dr. Saima, open your mic.
Sir, in a newly diagnosed asthma, in a case of OSCE, along with spirometry, should we ask CBC and FeNO test too?
Yes, CBC you can add also, not only to see the eosinophilia, okay? Not only eosinophilia, we discussed that we can see in the features of infection remaining there anywhere because asthma is a trigger factor for the asthma also. Infection is a trigger factor for the asthma. Dr. Saima, you can add,
Okay, sir, and like in my OSCE case, was there was an okay,
please.
there was a exercise induced asthma, young
Okay.
patient.
Okay.
So I asked for FeNO and spirometry to confirm the diagnosis, but how to explain FeNO and is it? I haven't seen FeNO in real life practices also.
But Pheno
How
is,
to explain?
yeah, Pheno actually we don't use in regular practice. It is beyond the availability of most of the GPs in South Asian countries. This is a nice guideline, it is a UK based, and they are utilizing it very randomly, but not us. Even then, in the explanation part, we have to say something in the layman term. Okay, you have to expel. Okay, exhalation. There are some devices small and patient is to blow out the air and they will detect this. Up to this, no need to say some scientific issues. It may be not in our grip also, right? All the things, BPM, other, no need to explain. You just say that you are I am sending there. This test is not very critical one. Just as I'm telling about the OSCE candidate, then you have to blow. There will be a small device and you have to blow it. You have to blow your air out and they will detect something there and they will give the report. That's all. Not in a very critical. Dr. Saima, why you again switched off? Very simple thing. Any other question you have observed, doctor? other than this in the asthma? Pheno and others. Again, the spirometry also same. Blowing out. Okay, blowing out. This is for the layman term only, nothing else. No need to explain, because if the blowing out spirometry, it is 400, 200. It should not be in a practical the OSCE exam. Unnecessary, it will cut your time. Just simply encourage the patient and go there. After getting the report, then you will explain. Not before that. I think, am I clear to you, Dr. Saima, or other colleague of us OSCE today or not? Anyway, let me proceed now. You can ask later also if you
Yes,
have
sir.
further
So
question.
much.
Okay. So this is the dose,
Sir, one
moderate, high dose. Any other question, please, Dr. Saima, as you open the mic. You might have some trouble maybe, okay?
sir,
Yeah,
regarding CBC, if there is no acute examination,
no
it will
need.
be okay.
No need, no need.
What do you say about CBC? If there is the patient is
Suppose in the OSCE
okay,
station, no exacerbation,
thank you.
you are just having the little breathlessness, mild cough, there is a rhonchi and other, clinically you are confident this is asthma, only to say that I like to confirm your diagnosis or the disease by doing a test. It is called pheno. Okay. And surrogate technically tell pheno doctor or examiner also sometimes that pheno is not available in India, Pakistan, and then what will you do? It's a very practical question. Okay. But in the AKT question, pheno is the single best answer, because you have seen already guideline telling pheno number 1. But in real life, practical exam, spirometry with BDR. BDR means bronchodilator reversibility. It is a practical answer. Okay. Okay, let me proceed now. This is the different doses, okay, low, moderate, high, because I will utter this word in subsequent slide. For example, in the budesonide, for example, 400 to 800 and 800 more than that. A little difference will be there. You see 200 to 500, then again 600 to 800. But our target is 800 here. A little variations will be there in some author telling in this. That is the reason I told you the asthma authors are more in the world. But on in general, you can follow this for the budesonide. Less than 400, more than 400, more than 800. It is easy to remember for the budesonide. If you cannot remember other drug, you practice with the budesonide, doctor, in your real life. So this is the high dose, moderate dose, and the intermediate dose steroid. Okay. Now we have to utter the word. It is called the uncontrolled asthma. When asthma is not under control. This is the explanation of the uncontrolled asthma. Okay. Again, even the single exacerbation, patient needs oral steroid. It is one of the features of uncontrolled asthma, and there are other features also. You know already. Now, if there is an exacerbation, you will step up the medicine. Right? For example, in our previous case, after doing the peak expiratory flow rate, you found that peak expiratory flow rate is less, and you were thinking that I need to step up. But before stepping up the medicine, this is the family medicine highlights. Exceptionally, family physicians are very keen to know about this thing. And in the OSCE exam, you must explore it, remember. Otherwise, if you say, like today somebody said that I will give bronchodilator or increase the steroid, it will not be correct answer. There will be mistake. So check the adherence, check inhaler technique, SS trigger, especially inhaler technique is must and mandatory in your OSCE station. SS trigger exposure, smoking or other allergens, SS control with tools. Sometime we don't practice it usually, but academically we must know that there is some tool. Especially there are two tools. GINA, you know about the GINA, the global initiative for the asthma. We will discuss also a little from them. This is one of the author. They have developed some tool and very easy. Already I have shown you before. There are 3 or 4 features are there to say uncontrolled asthma. Even then, there is some scoring system. 4 question assessment in the GINA in the latest development 2024. Well controlled, partly controlled, and uncontrolled. So what are the questions are there? Daytime asthma symptom, any night waking, reliever needed more than twice per week. More than twice, not 2, more than 3 or more, rather to say 3 or more. It is also written in the previous box. Any activity limitation due to asthma. So from there, if Your score is 0, well controlled. 1 to 2 score is partly controlled. 3 to 4 will be uncontrolled. So accordingly, you will take the action. If it is well controlled, then you will follow the patient, consider a step down. If stable, more than 3 months, 3 months, that means you got the history. This is a part of critical area of the management decision. You're already facing a patient now, and you know the history. Your scoring is GINA symptom control tool. According to tool, you thought that is a well controlled asthma, and in the last 3 months or more than 3 months, patient actually quite okay. Then decide step down. Then decide step down. So how many months usually after a step down? Who can say? Usually these are 3 months. If patient is okay, minimum 3 months, then we will step down. So it can happen in the follow-up patient few years later. But initially it will be a step up. I will show you how to step up. So usually a step down should be after 3 months, minimum 3 months. It may be 4 months, 5 months, 6 months, depending upon your decision. If the partly controlled, again, review trigger, adherence, technique, consider a step up now. Your decision making, step up. If partly controlled, after considering trigger, adherence, and technique. If mistake is there, if you step up the medicine, there will be again chance of failure. Again, if it is uncontrolled, definitely you need to step up the treatment. And after stepping up, you need to reassess the patient in 2 to 4 weeks. Usually after 1 month, but if it is uncontrolled asthma, better to follow the patient up after 2 weeks. These are very important for the OSCE doctor. In the AKT, they may not be too much critical because in the OSCE, you will deal the patient specifically asthma. You need to know it. How many days later you will monitor the patient. Don't think that this is a part of pulmonologist. It is your job. Then, when to step up? After starting the treatment. If control is not achieved, 4 to 12 weeks. That means after 1 month usually. Step up. That means you started your medicine with the SOS, SABA or whatever, plus inhaler, steroid, including LABA or else. Then tell the patient come back after 1 month, usually after 1 month. But it may be again, if you are follow-up patient, not the first time, patient may come after 3 months also. Because you know, to step down treatment, our decision will be after 3 months. So how to say? Dr. Saima, how to say to the patient to come back? Just can you practice now with us? Patient is a follow-up. Patient is on asthma treatment last 4 to 5 years. And you're telling to come back. Dr. Saima, can you tell us how to tell? Any other colleague can try how to tell to the patient as a part of OSCE. Dr. Gulzar, please. How to tell to the patient?
If there is any
No. Sorry. Be lively. Be lively. You are talking to the patient. Your patient is Mr. John. You are talking to the John. Come back after 3 months. You are already given the asthma treatment and you are thinking that everything is good. How to say now? Yes, Mr. John, come back after 3 months if everything is okay for you. Right? Everything is okay for you. Why I'm telling in this way? Because patient may have again breathlessness within the 3 months. So you have to explain it. If everything is okay for you, come back after 3 months. Okay? If it is a follow-up patient, you know your patient from before. But for the new patient, come back after 1 month. It will be the decision. Because we need to decide for stepping up the treatment after 1 month. Okay. And again, timing. How to step up timing? Again, we are following the GINA guideline. In this situation, step up decision can be after, you see, for some patient 12 weeks, 3 months. For some patient 6 weeks, that means 1.5 months. According to the category of the patient, that I like to hear from you. Stable patient starting new controller. Patient is stable, no problem. Okay. Then 6 weeks. Persistent symptom despite treatment, 4 to 12 weeks, 3 months. Dr. Tuba, please.
So we can also ask the patient that they will come if they get any problem from our treatment. he can come after 1 or 2 days, or
Immediately,
whenever
immediately.
he gets it.
Yes, doctor, immediately.
Yes,
Immediately. We will not follow this week and other. Immediately. If any new problem, it is
yes,
called the safety netting. Very important for
yes,
OSCE,
yes,
safety netting. We have to say what problem
yes,
might happen and what patient is to do. This is safety netting. This is separate thing. Okay. But for the AKT exam, these topics are not important. AKT is straightforward answer you like to know. So acute worsening, viral illness, allergen exposure, acute worsening, again short term, step up immediately. Short term. So patient will come back and increase ICS 7 to 14 days, 2 weeks steroid up. Again, it will be lowered down. This is exceptional, right? Frequent reliever use or exacerbation. Frequent patient is to use frequent reliever or exacerbation. These are the features of uncontrolled. So whenever uncontrolled, consider immediate step up. Immediate step up means that is the thing what you said. Come back immediately, then you will step up the medicine immediately. Don't wait even the 1 month also. So 1 month is a matter if patient becomes stable. If patient is unstable, patient should come back before 1 month also. This table is actually telling this thing. Now, our main focus of today in the aged 12 and over. This is the latest guideline and accommodated by other authority. This is very interesting. And you see now, we divide the patient in two groups. One patient is old patient. Most of the patients actually old patient in your practice. You were practicing long time in a place, maybe 5 years, 6 years. So nice, BTS, sign. Three authors combinedly has given this decision. So it will be the best decision in future exam also, even in our real practice. So divide the patient into old patient and this is the new patient, newly diagnosed asthma. In the left one, existing diagnosis of asthma. So two group. In the existing asthma, what would happen? You will see that some patient is only with the SABA only. SABA. Another group, SABA plus something. Second, you follow my cursor. SABA plus something. Okay. What other?
Lama.
No. SABA plus other medicine means low dose ICS, low dose ICS LABA, low dose ICS plus LTRA, or low dose ICS LABA plus LTRA in any group of the patient. But SABA SOS. If this is another group, third group, SABA plus the same thing. SABA plus same thing, but dose is moderate. You see here dose is low dose steroid. Here in the third group, dose is moderate group. Moderate dose steroid combining other medicine almost the same. So in the second group, low dose steroid. In the third group, moderate dose steroid. This is the main keyword. Okay. And another one, maybe if asthma is uncontrolled on high dose ICS, it may be another group. So if you say 1, 2, 3, 4 group are here, okay. If those are under control, what is our decision? Doctor, a quiz question to you. Old patient under control, whatever the medicine they are getting under control, what will be the decision? Please respond. Very critical area.
We can ask the
Continue
patient to
the
come
same
back after
medicine.
3 months.
Yeah, decision will be continue the
Come
same
back after 3
medicine.
months.
Continue the same medicine. Continue the same medicine. This is old. For example, old and we are following the old strategy. But we will change our decision if it is uncontrolled. You see the word uncontrolled here in this group. Then we will try to switch to the new approach. The main word of the new approach is MART therapy. What is the meaning of MART? Please, doctor. What is the meaning of MART?
Maintenance and reliever therapy.
Maintenance and reliever therapy. What is the advantage of maintenance and reliever therapy?
You are giving both together. This reliever means bronchodilator and steroid maintenance.
So we are also giving the both here ICS and the LABA. These are maintenance reliever. SABA both are there.
But that are separate. Actually, that are separate. But this one inhaler will be the same.
Same
inhaler.
inhaler. Economically prudent. Patient compliance will be better. So this is an study-based, evidence-based informations. Okay, and you can compare with previous NICE guideline. Is a different one. MART therapy was one of the option there, but here a complete option is the MART therapy. That is the area where if you go through AKT in the question bundle till now available in the market, you will be wrong in your decision making. There is no other way to say it. Okay, Dr. Javed and others. So we will for example, those who are our module user, we will, this is one, first day is our initiative to let you know that you need to modify your decision making in the question bundle. Okay, other basic informations are there regarding the asthma treatment. In the option A, B, C, D, E, your decision will be changed. Okay, and this is very important discussion for you, and hopefully we will update the topic today in your module bundle also. This record will be there so that you can modify your answer. Still, this is our responsibility. If you don't understand, we will try our best to guide you also for further decision making. So now follow this thing. Newly diagnosed, then start with the MART therapy. And again in the MART therapy, low dose, moderate dose. How low dose is there? Based on the steroid dose, not other medicine. So again, we already discussed before. Low dose means what? Maybe formoterol, maybe budesonide. But in the MART, which is preferred LABA, who can say? This is also LABA. In the MART therapy, the philosophy is that there should be relatively short-acting LABA. It is called the rapid-acting LABA. LABA means long, but another word, adjective is rapid-acting LABA. Means immediately patient will get the relief like SABA and SAMA before. So what is that steroid? Can give immediate relief? It is a budesonide, beclomethasone, formoterol, vilanterol. What? Nobody can tell. This is formoterol. Formoterol. Prednisolone is oral drug, doctor, separate thing. But the inhaler, SOS medicine, formoterol. You can see in this green box. Offer low dose ICS formoterol combination. It is called AR therapy, AIR. Anti-inflammatory reliever therapy, AIR. It is just as a counterpart of SABA only. In the new approach, steroid plus rapidly acting LABA. Is not different, doctor. Dr. Javed, as you are very good colleague, I am asking always to you. Other colleague also can share. I think you understood it.
Yes.
ICS and formoterol will be SOS medicine. SOS medicine in the MART therapy, MART algorithm. Again, in the MART, categorically low dose and moderate dose MART. Okay, is still uncontrolled. Again, you see, whenever uncontrolled, again check the adherence, inhaler technique, trigger factor, always will be there. Then decide to go up. Then even check FeNO level if available and blood eosinophil count is still. Okay, if anything is high, already you have given the steroid therapy, then think that patient is beyond your control. Then you need to refer the case to a specialist or asthma center or asthma care center. But neither is raised. You have given the moderate dose MART, neither is raised. Then you can add with the MART other thing. What other thing? LTRA. Who can say LTRA means? Leukotriene receptor antagonist. Is it? LTRA. Or LAMA. LAMA means, doctor, please be with me. Please be with me. Help me. Whenever I am asking, respond, please. LAMA means?
Long-acting muscarinic antagonist.
Muscarinic agonist or antagonist? Antagonist. Yes. Antagonist. SAMA is short-acting muscarinic antagonist. LABA is long-acting beta agonist. So this is also a question. Someone is agonist, someone is antagonist. So this is antagonist. Now used in addition to moderate dose MART. So you see moderate dose already patient getting, and add these LTRA or LAMA. Remember, because already you have started with the LABA, rapidly acting LABA like formoterol. Now you are adding LAMA or LTRA, anyone, not both, anyone. Suppose you started with the LTRA and observed again 8 to 2 weeks. That means 2 to 3 weeks. Then check again features of control. If control is there, continue treatment. If control is improved but is still inadequate, second word, remember, second sentence. If control improved but is still inadequate, adequately not there, continue treatment and start a trial of other medicine. Other medicine means if you start with the LTRA fast, then start with the LAMA. Okay? Understand, doctor? Other medicine means better you can stop the LTRA, then start with the LAMA. Maybe decision will be like that. If control not improve, okay, stop LTRA or LAMA. Means what you are using, you stop it totally and start a trial of alternative medicine. So almost the second and third one is almost the same. That means if control is inadequate, okay, control is inadequate, you can continue the previous medicine and you can add other one also. You can add other one also here, or you can alternate also with other. Other means LTRA or LAMA oblique alternative. You can start with the LAMA fast also, other than LTRA. That is the Montelukast and other. LAMA you can get in the same inhaler also, right? Or a triple. Nowadays triple drug available. Is it? Triple drug. We use advice for the COPD patient. The formoterol, ICS, that means the corticosteroid, as well as LAMA, long-acting muscarinic antagonist. Can anybody say example of LAMA? Name of the molecule?
Tiotropium.
Tiotropium. Other? Glycopyrrolinium. Is it? Glycopyrrolinium. Many others available as a LAMA. So we may get triple medicine also. So if inadequate, you can decide to continue the same medicine plus other drug, or you can stop. Especially if control is not improved, you must stop the LTRA or LAMA because it is not giving benefit. Then switch to alternative, another one. But MART therapy will be continued as moderate dose. Okay. At that time, again, asthma uncontrolled, again referred to specialist. So this picture should be in your mind so that you can say your decision perfectly evidence-based. This is our main target today. So my question to all of you, doctor, if you don't understand anything, this is the main area of today's discussion. You can raise your hand and open your mic also, doctor. Please, any colleague to ask about this algorithm. It is not like our previous algorithm is something going up a stair to the peak of the hill or mountain. This algorithm is, it actually is an algorithm, stepwise progression. Any question in your mind?
Yes, Dr. Usman, can I ask something?
Please, why not?
Yes, if patient not, I'm coming to the last, if not controlled or LTRA or LMA together also.
Yes, yes.
So you can go to the alternative medicine. So that is monoclonal antibody or something else?
That is the thing. If you are a specialist, pulmonologist, this is your privilege, but not as a GP. It is not your privilege. And guideline also not telling this.
I think it's
Remember
the
it.
monoclonal antibodies.
They will do. They will do. Specialists will
monocular.
do this thing. Even we are practicing with the aminophylline or doxophylline also. We are adding this. Is in a specialist point of view, you can add. But as a GP, according to the guideline, they are not advocating that to add aminophylline. Okay. They are not advocating to add oral steroid also. Can you see now? Doctor, please, everybody look at. Previously in the guideline, there was addition of the 20-30 milligram steroid. OC, it is called oral corticosteroid, OCS. Oral corticosteroid in the previous guideline. In the step up in the later part. But this one, they are not telling to use a steroid here. as oral tablet. You do in your practice, no problem. But for the exam, be sticky with this guideline and try to remember in a very picturesque manner to decide. Otherwise, there will be mistake. And this is mainly highlight of today's discussion, Dr. Javed. Okay? It is a
So oral
decision making.
will not mention in the exam. That
Yes,
means.
you see, there is no mention of oral steroid. And that is the area, doctor. I told you already, I have given a click to you that the steroid induced side effects, oral candidiasis, even the Cushing syndrome. In the last decades, we observed that patient develop Cushing syndrome due to abuse of steroid. Maybe this is the reason. Guidelines are not guiding us to actually prescribe oral steroid. Clear? Any other
Thank you.
observation? Any other observation?
Thank you. It's clear.
Fantastic. Fantastic. So now, just a little thing for the pediatric, as you are family physician. I will not tell much more. It's almost similar, but there is some difference in the pediatric. Again, there is a MART, though MART is actually not licensed. It is called licensed, another is off label. There's off label. You will learn by yourself what is the meaning of off label. Not by the guide. What I say, the local authority can decide in many ways. But for your practice purpose, you can know that in the pediatric also there is a MARD regime. Baby cannot tolerate MART also, okay? And there are some device also babies to use, especially age at 5 to 11 years. After the 5, they can use the peak flow meter, they can use the inhaler also. But below 5, unlikely. You see there is an SABA added with ICS, offer twice daily pediatric low dose ICS. So you started not with MART. Am I right? In the pediatric group. In the adult group, we started with the MART. Is it? Or you go back to compare. ICS for Moterol. This is MART. ICS for Moterol. Okay, but in the pediatric 5 to 11 years, the twice daily pediatric low dose ICS. So there is no formoterol, remember it. But SABA is there SOS. But in our previous one, there is no SABA because it was MART. But again, now if you assess ability to manage by the MART regimen, then decide in the right column, in the left column. If baby able to manage MART regimen, then low dose MART, okay, increasing to pediatric moderate dose MART with the same principle. So if moderate also not useful, then refer. Same with the adult. Here in the right side, if MART is not applicable for the baby, go to the traditional regime, and this is the decision making. So we'll go through by looking at your guideline, doctor. Okay. So again, moderate dose ICS, then refer. Remember it. Not high dose. Dr. Javed, do you understand? Actually, guideline not allowing us to give high dose steroid. This is the principle. Understood? Guideline is not allowing to advise high dose steroid. But before, previously, it was so. Am I right, doctor, for all of you? I think. Then decision is the referral. But in your practice life, in your workplace, you can do. But for exam, remember it. So it's the main area, doctor. Still, if you have any query, you can raise your hand, doctor. Okay. If no one, we can see now patient. Few patient now to decide. Again, may I request anyone today other than Dr. Javed? Dr. Javed is always friendly to us. Any other colleague to open the mic and read the patient other than Dr. Javed? Yes, Dr. Tuba, please. Thank you.
A 45-year-old woman who is non-asthmatic come for review. In the past 2 years, she has had around 6 observations of asthma acquiring oral corticosteroids. Her current medication includes salbutamol 2 puffs, PRN, and betamethasone 200 mcg 1 puff PD. How will you evaluate now?
So patient had history of exacerbation. Okay. Not under control, is not it? Dr. Tuba, please keep your mic open. You read, then gone. Why? Please. So patient condition is good or bad in your assessment? Simple
Bad.
question. Bad. So how will you evaluate now? You will evaluate by What? You note that record. You will see the record of the BMI, a smoker, and good inhaler technique. This is your evaluation today.
Yes, 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 yes.
After that, what will be your next management? Actually, I customized the question. In the equity bundle, question was not as before, doctor. Please follow me. I just modified the question for you. Next thing, how will you evaluate means first not give any medicine or further. Evaluate this thing. Inhaler technique,
Yes.
other, patient is smoking or not, any exposure to dust and other, everything. Everything is good, nothing wrong. Then what will you do? Please decide. Everybody
Yes.
try to share in your answer,
Increase the
please.
metabolism.
What will you do? Increase beclomethasone.
Can increase the
Okay, other colleague. Even you can say another answer beyond this 5 also. Remember.
Yeah.
Dr. Javed?
C.
I please follow me. I am telling that you can add EF option also. It is hidden. If you think it would be better, best answer, not even from 5. But traditionally, you are selecting something there, someone A, someone C. But what our guideline is telling now? Dr. Tuba and anyone, please. What our guideline is telling now to decide? Is it from A to E or something else?
we can increase the dose of steroid
That is the
of
thing.
option
That is the doctor. What I I mean, there are 2 column. Our previous group. This is the new approach according to the latest guideline.
Yes.
Previous group, you would increase steroid, but patient is uncontrolled.
Now we can
So what will be your decision
add
now?
formoterol. We can add formoterol.
Add or replace?
Replace.
Doctor? Replace means your decision will be what? Low dose MART or moderate dose MART?
A moderate dose.
Moderate.
Low dose MART.
What was the steroid dose again? To 100 microgram beclomethasone. It is a low dose steroid. Okay?
Low dose.
How tricky it is. What you are practicing, we are not practicing accordingly. For this reason, your answer will be wrong in your exam. If patient is on low dose steroid, I will choose low dose MART. Okay, Dr. Tuba?
Yes.
That is the decision. But why you are again in the darkness? Sorry to say. Until now, we discussed a lot. This is our target. Recent update. We will not be in the same line further. Okay? So that is the thing. Again, I like to say in your question bundle, our module user, remember, whatever the authors you have collected, modify your answer in your question bank. Decision will be low dose MART. Okay, I believe in the coming years, the authors, for example, whatever you say, past medicine, on exam and past test, they will modify the answer according to the guideline. In advance, we are telling to you for your benefit. Okay, Dr. Javed. Dr. Javed and others.
Yes, clear.
For this in advance, we are telling you. So you should not be feeling bad to us. We are giving some wrong thing to you. Actually, we have collected from them past medicine and it's very popular to you. So this latest idea. So it will be low dose MART. If patient before high dose steroid, it will be the high dose means moderate dose, then it will be the moderate dose MART. Then follow the patient up. As you change this, what will be the monitoring duration? How many days after? Is it after 3 months, 1 month, 2 months? This patient?
1 month.
At best 1
1
month.
month.
Right. 1 month. 1 month. Very right. These are intelligent questions. So this is the big picture for you. I hope you will not do the mistake again. Dr. Tuba, will you do the mistake again? No.
Until I will not.
I hope. We hope no. Next patient. Who will read? Next colleague. Doctor. Again. Who want to read? Feel free to read, doctor. It will be useful for me as well. Dr. Gulzar, please.
Yes, I will read.
Yes, please.
27-year-old man present for review. Around 6 months, he started work at a garage which specialized in the spray painting of cars. Over the past few weeks, he has been having increased problems with cough and wheezes during the daytime. He wonders if it may be related to his work, as his symptoms improved following a recent 2 weeks holidays.
What is the investigation plan for diagnosis? Answer, please.
There
OSCE, my beloved OSCE participant first, because it is not the AKT format. It is an OSCE format question asking you. Any OSCE candidate should answer it first.
peak expiratory flow
Peak expiratory flow rate. You will do this for diagnosis. Okay. Other colleague, any different opinion? Telling nothing.
Spirometry.
No, Dr. Javed. Peak expiratory flow rate. And this is the part of your question. I just cut it, make it shortcut for you. You give him a peak expiratory meter. This is your decision. Okay, Dr. Javed? It is an exceptional thing. It is occupation related. And some doctor said, Dr. Saima maybe, right? Your previous experience? Occupational asthma? Oh no, it was an exercise asthma you said before. It is occupation related asthma. In that case, peak expiratory flow rate actually the top most important diagnostic tool. Because he used to go with this flow meter with this workplace doctor. In the workplace, who will do a spirometry? Understand, Dr. Javed?
Yes.
But patient can carry this meter. Isn't it? For this reason, you have given it. And you found this result at the workplace and not in the workplace. So there is a gross difference. What is your diagnosis now? Asthma. Occupational asthma. Then what will you do? Most appropriate course of action. Again, question to OSCE candidate. What will you be decision after getting the peak flow? And this is a stepwise management plan, doctor. Already you have seen in our discussion in the OSCE, there is number four skill is management skill with investigation plan. In the fourth skill, you will give the score if you decide peak flow, not directly to spirometry or other test. For the diagnosis peak flow, then, yes, doctor, what will you do after getting the result peak flow value? Sorry, doctor, telling nothing. If nothing, go back to AKT, doctor. Sorry to say. That means you are not prepared for OSCE. Don't mind, eh? You are not prepared for OSCE. You passed AKT. Again, go back to AKT. Refine you, then come back to OSCE session. Telling nothing again. Choose there from there. Anyone from this option. Refer. Will you not start treatment, doctor, with this? Steroid, LABA, SABA, whatever you say, prescribe salbutamol, arrange a spirometry, advise him to quit the job. Doctor, please explain why are you referring? You are not giving treatment. Other colleague to say something more? No more.
Yes, change of occupation.
Change of occupation. Is it easy, doctor, to say that who will
It
give
is
money?
written actually that occupation have to refer.
Written means what is
Sir,
the
it is
reality?
written.
Written,
It is written in
okay.
Oxford or somewhere.
You are right, doctor, but what is the philosophy behind writing this? Why it is written? Your answer is right. I'm showing you. Yes, refer. But what is the philosophy behind this? Because to quit the job is not very easy to decide, Dr. Javed. Okay, who will give the money to him? And if any person suffer from the work, they should have compensation. It's a critical job. Okay, not that any are giving, because if patient is still in the environment, patient will suffer. So medication will not work. We cannot give both together. Go with these and continue the medicine. So medication is valueless decision here. Rather, advise him to quit the job, maybe the answer, or refer. In these two, Best is the referral, not quit the job, because quit the job doesn't give the value. Who will give the what I say, compensation? So we have to send to the respiratory specialist, and sometime it will be written as occupational health authority also. Could be there because this is occupation related disease. Clear, Dr. Javed? And it is written in the guideline, whatever you say in the text, and I agree with this. The referral to the respiratory physician is important. And serial already occupation related, we have shown you the serial measurement by the peak flow meter, already we discussed before. And referral should be made to respiratory specialist for patient suspected of occupational asthma. It is an exceptional case. Dr. Javed, are you there? I think clear for you.
Yes, clear, yes.
Thank you very much. Thank you very much. Next patient, who want to read? Other colleague not feeling interest today to be with us to read the patient? Dr.
Sir,
Saima,
I have
please.
a question that
What question about going
sir,
back?
I have
Please.
question. Sir,
In this
for
case.
occupational asthma, if we are diagnosing, can we write a letter to the boss to change the nature of the job in OSCE?
It depends upon doctor, but your decision, it depends upon OSCE will be a practical exam. Okay. In general, your straightforward decision is according to this thing. You will send to the respiratory specialist. They will decide, they will write the letter. But if you think that there is no respiratory physician around, patient wants that you have to do something, you will compromise with the patient. It is called mutual understanding. Will be a little different from the guideline or other usual steps. In that case, by mutual understanding, you can write to the author a letter, then side by side, you will refer to respiratory physician, both, not only one decision. Doctor, you have gone asking the question after Dr. Saima. Better to be with us. Throw a question and left. Okay, you are hidden. I think you got the answer, please. It's a practical situation will be a little different. You can decide both, not the best answer only. As a reality, you have to do something more also. Okay, even until patient go to the respiratory physician, it may take time, 2 weeks, 3 weeks. In the meantime, you can give some symptomatic relief by bronchodilator. Though this is not the best answer, this is not the best policy. Clear, OSCE candidate? Don't be biased with AKT decision. For this reason, today I am trying to segregate AKT approach and OSCE approach. OSCE approach will be practical approach. Only referral is not enough. You have to do something. And that is South Asian OSCE. Many often we discussed it, that our candidates are simply referring the case, doing nothing. So as a part of the management, it is incomplete management. You have to do something. Patient should have some minimum symptomatic relief. Okay, next one. No one open the mic. So let me read for you. Okay, Dr. Tuba again, please.
Yes. Your next patient is 34-year-old accountant who has come for their annual review. Following a series of observations, he has started down corticosteroid inhaler and currently takes quinine, betamethasone, dipyridinate, 400 mg
Microgram. Okay, 400.
microgram BD. The patient reports that his asthma control has been good for the past 6 months, and so his peak flow today is 520 liter per minute, which is better than the value recorded 12 months back. His inhaler technique is good. What is the most appropriate next step in the management?
So my question to all of you, is it good situation? Good means
Yes, good
asking very
situation.
simply, good situation, Dr.
Yes,
Noha.
good situation.
Yes, good situation. But now your decision will be a step up or a step down.
Step down
Why
Step
down?
down.
Why down?
because improvement of peak flow rate.
Improvement is enough answer. Only improvement is enough, or there is a timing factor.
Yes,
Improve
control
for
from months.
6 months. But what is our cutoff time? 3 months minimum.
3 months minimum.
Minimum. So
Yes.
now control 6 months. So for this reason, we are thinking that to step down. Is it? So my beloved again, OSCE candidate, what dose you will advise now? If a step down, always a step up, down means actually a steroid modification. So patient getting
Yes.
400 microgram BD. If it is a step down decision, what will be the decision now?
It's
Low
200
dose,
Low
200.
dose.
200.
Doctor, you if you say in the OSCE low dose will not be enough, doctor. It's a practical exam. You have to say according to your prescription.
200 microgram per BD.
200 microgram BD. It is a AKT question again. But in the exam, if you say I will minimize the dose, but you must know what will be your minimum dose. What is that? How many usually trending to reduce it? So this is the answer. 25 to 50%. 25 to 50%. Okay. If you think that this is not 6 months, a little you are confused. Okay, don't reduce 50% together in the initial time. You can reduce 1/4, minimum 1/4, but you are very confident. You are happy. Your patient also happy, right? Then, so you can reduce 50%. This is was one of the deciding factor, doctor. Okay, and try to remember it. Try to remember it. Okay, I think you understood. Every 3 months, not before. So patient should be happy. Minimum 3 months. Step down. So is it enough, doctor, for today for asthma management or anything in your mind further? Please. Any question further in your mind? In real life, actually, we tried our best to show you in real life what happening to us about the asthma as a GP, not a specialist. Remember, as a GP is to follow the guideline that we discussed today. Any further query in your mind regarding, are there any question in your mind? Near about 50 participants here, doctor, my beloved colleagues. Thank you, doctor, who have given the heart sign to us. And the same to you as well. Dr. Gulzar, your mic is on. Any other colleague? If everything is understood almost to you, we will be very happy. And this is the praising to Almighty that we tried our best for you, you understood. And last is your follow-up plan in annual follow-up. After talking everything to the patient as an OSCE candidate, your next plan, okay, come back after 1 year. If like today, our patient, everything is okay, but a step down should be reviewed a little early. Isn't that it? If you think that patient is to continue the medicine without a step down and everything after 1 month, everything is going okay, then maybe 3 months, it will be again modifiable. But in general, everything is okay. Follow the patient up after 1 month. It is called annual follow-up, annual review. Again, tell the patient, come back if anything happened wrong before 1 year also. After 1 year, you will do it. Assess the symptom. Again, review the smoking status, any features before exacerbation, medication use, examination. That is a peak flow meter. Already you said the follow-up. Education about this monitoring allergens. Home chart already I told you there is home monitoring. In the peak flow meter, there is a color coding also there, you know. So check everything. And goals in the next review. Next review, again, you may decide next review maybe after 3 months, maybe 6 months, maybe 1 year. So I think that's all, doctor, for your asthma management. And if no further query, we like to thank you to invite and to be with us in our, what I say, YouTube. Many other videos are there. Okay. And this is this doctor invitation. Those who are new, if any new doctor, just give me a few second time in the chat box. We are putting. And those who are examining, just be with me a few minutes more. Even coming for the AKT exam. Somebody want to talk to us individually. We don't have enough time. So this first link is for the AKT group, doctor. And the next link will be there for your OSCE group. Any new colleague want to join with us, you can click there immediately, you can join. So our next topic planned is COPD updated management. Okay. And if I ask you feedback today, any colleague want to tell something about today's session? Did you get benefit or how was our session today? Any colleague want to say something or any further suggestion? If you continue in this way, also future, will it be beneficial for you? If it is so, we will organize other topic for you, Doctor. Dr. Javed is here, please.
I think Dr. Usman, COPD better, I think, because related, I mean, is mixed up with the asthma always.
My question is not to
Yes.
you also, everybody, that what we discussed about the asthma, the technique, strategy we adopted today, is it useful for you?
It's
To
become very
preserve.
clear. Many things become very clear.
But you are saying, but other colleagues saying nothing.
No, no, it
Yes,
is
sir.
very useful. And
If
Useful
it is
for us.
useful, we will follow the strategy also in the coming
Yes, yes.
time. Okay.
It is useful for us.
And we have selected the respiratory related maybe in within few days, but in between we may have some other extraordinary topic also. But according to the academic topic, the COPD updated management we will make by the mercy of Almighty will be in front of you soon. Okay, right. And for this is that the candidate, those who are not in touch, already inviting you, doctor, maybe 3 months or a little more than waiting for you for AKT. And I will show you for the OSCE candidate also. You can communicate with us with this benefit for the coming 3 or plus days. Okay, better not to discuss much. Already you know in the group and even a little. Dr. Tuba raised hand to ask something maybe.
Yes, sir. I am not giving MRCGP, but I am still taking your lecture for my to improve my practice.
Very grateful to you, doctor, that you are here with us. It is very, what I said, inspiring for us you are here, Dr. Tuba. Gratitude to you.
Thank you, sir.
And I know Dr. The Arvind also started with us. Where is he now? Maybe busy. He already passed OSCE in the last time. Again, maybe some few colleagues also like you. Gratitude to all of you, doctor, that you are with us. And it is fact. I know, and because we are preparing, it is not only for the exam. It will be useful for your practice. So we want that you will be again with us, doctor. Thank you again. Thank you more. And regarding the OSCE, this is our plan in the meantime, though we already made a very basic module, mature one. Even then, if you want to practice with us for the coming November OSCE exam, there will be 50 case practice session. This is a planning already, but we will finalize. OSCE candidate communicate with us. This is a practice session, not the record. Record will be available after the class day if anybody miss the class live session. Okay, preferably in the Sunday and Thursday, 5:15 p.m. Saudi time. You can adjust your country time accordingly. This is a 50 case, and we'll discuss about the different category of the OSCE. We discussed before acute case, chronic case, breaking bad news, counseling. We will try to give you 10 different category and total 50. So there will be minimum 50 case to be practiced by each candidate. Opportunity will be there, minimum 10 case. So this is for OSCE, and this is again the OSCE basic module. Is the version 5. It is updated one. If those who are using, you can communicate. If you don't have the latest one, version 5, you can write to us. We will provide you. So this is for you, doctor. I think better not to take much. You have given more time. This is the beyond the MRCGP with us, okay, including the MRCP. So thank you very much, doctor, for your patient hearing and cordial participation. And keep us in your prayer all the time so that we can do something for you. All the best. Ma'as salama, doctor. See you.